Welcome, and we will have a presentation first and then discussion. So if you have any comments, you can write them in the chat or send them at the Q&A, or raise your hand and we can open your mic so you can talk.
Great, thanks, Alex. So welcome everybody to this month's edition of Heart Muscle Talks. My name is Perry Elliott. I'm Professor of Cardiovascular Medicine at UCL, Barts Heart Centre, and we're very pleased today to have a presentation from our colleagues in Paris. And our two chairmen today will be Eloisa Arbustini from Pavia and Kostas Servatis from the Barts Heart Centre at UCL. So I'll hand over to my two chairmen for what I'm sure will be a very exciting presentation today.
Thank you, Perry. I think we can start. I would welcome Leslie Motté and for this interesting presentation that we expect really to help us in understanding best use of ACEinhibitors in patients with dystrophin gene defects. So Leslie, welcome. My co-chair want to say a word to welcome to Leslie, please.
Yeah, welcome from my side as well, and we're looking forward to listening to your talk.
Thank you.
So please, Leslie, go ahead.
Okay, I will share my screen. Do you all see the presentation?
Yes.
Okay, so hello everyone. I'm Leslie Motté. I'm a fellow student in the cardiology department in Cochin Hospital in Paris. And I've been studying genetic cardiomyopathy this year, and especially Becker and Duchenne muscular dystrophy. So on behalf of the authors, I will report the results of this study regarding the association between prophylactic ACEinhibitors and overall survival in Duchenne muscular dystrophy. This study has been published last year in the European Heart Journal. So first, some reminders about Duchenne muscular dystrophy. It's X-linked genetic disorders affecting 1 every 3,500 live-born male infants. It is due to mutations in the dystrophin gene, leading to a lack of dystrophin in muscle cells, causing a progressive muscular disease. Clinical onset occurs at the age of 3 to 5, leading to loss of deambulation at the age of 7 to 13. And the patients usually die in their late teens or 20s from cardiac and respiratory failure. The use of corticosteroids changed the prognosis of this disease. However, there is no curative treatment for Duchenne muscular dystrophy. And to delay the onset of dilated cardiomyopathy, experts recommend to introduce ACEinhibitors by the age of 10, even if the left ventricular ejection fraction is still preserved. This is based mainly on this study, which is the only randomized prospective study, including a few patients from Duboc and al., showing that the preventive treatment with perindopril was associated with a lower mortality rate compared to placebo. However, the prophylactic use of ACEinhibitor is not a common practice outside neuromuscular referral centers. And nowadays, conducting randomized trials is limited by practical and ethical reasons. So that's why we choose to perform a retrospective propensity-based study using data from a large French multi-center DMD registry to assess the effect of ACEinhibitors in overall survival. So patients were included among the DMD Heart Registry, which includes patients from 8 French medical centers. The inclusion criteria were a clinical profile consistent with the diagnosis of DMD with a specific mutation, and the exclusion criteria were diagnostic before 1986, concurrent illness causing cardiac or respiratory disease, and when the date of treatment initiation was unknown. We then reviewed each patient medical record to collect several information on the patient's disease, on clinical events, and their medication. The primary study outcome was overall survival in order to take into account the competitive risk of respiratory failure and heart failure. And the secondary outcomes were hospitalization for heart failure and hospitalization for acute respiratory failure during follow-up, and it was confirmed by a blinded adjudication committee. Then we performed two different analyses for each outcome. In the first analysis, the effect of ACE inhibitor was estimated by a simple Cox model with and without adjustment for baseline variables. And in the second analysis, we emulated a clinical trial because this is a less based analysis in retrospective studies. So we include patients between 8 and 13 years old who didn't have any previous ACE inhibitors treatment and whose left ventricular ejection fraction was above or equal to 55% between January 1999 to December 2016. Then we divided the overall inclusion period into 72 consecutive 3-month periods. The date of inclusion was the date of treatment initiation, and the end of follow-up was the 31st of December 2017, or the date of death, whichever occurred first. For each treated patient, we randomly assigned 3 untreated patients, by this way simulating a 1 patient and 3 controls randomization. And then we compared patients' period instead of individual patients. So since the treatment groups were not randomly assigned, we used the inverse probability of treatment weighting to correct for confounding by indication, and then performed a Cox model analysis. So this is the flowchart of our study. As you can see, 576 patients were included in this first analysis from the DMD heart registry, and 412 patients were included in the second propensity-based analysis, with 2,078 patients periods in the treatment group compared to 834. I'm sorry, I said 1,000, but it's 100. This is a baseline characteristic of our patients. So the mean age was 6.1 years in the first analysis and around 10 for the second analysis because the inclusion began a bit later. The mean left ventricular ejection fraction was around 64% in both analyses, and 3% of the patients were treated by glucocorticoids in the first analysis and around 27% in the second analysis due to a change in clinical practice during the inclusion periods. So about the first analysis, the median follow-up was 13.5 years. The hazard ratio for overall mortality associated with the prescription of ACE inhibitors was significantly lower for the treated patients compared to untreated ones. And there was as well a significant association between preventive ACE inhibitors and hospitalization for heart failure, but not with hospitalization for acute respiratory failure. In the second analysis, so the emulated trial, we confirmed these first results. We also observed a significant lower risk of mortality among patients treated with preventive ACE inhibitors, and even a lower risk of hospitalization for heart failure. There was still no significant difference for the hospitalization for acute respiratory failure. So the strengths of our study was the use of a propensity-based analysis and the emulating trial. It also allowed us to take into account the change in the standard of care during years by comparing patients and controls in the same time periods. And our results were consistent with previous studies with the same magnitude of effect. Some limitations could be the retrospective design of our study, leading to several biases, and the assumptions on which relies the statistic models. And we also didn't take into account the drug doses. However, a complex and imperfect emulated trial remains the most sensible way to obtain reliable information on the potential effect of ACE inhibitors prophylaxis in this context. So to conclude, significantly higher overall survival and lower rates of hospitalization for heart failure were observed in the prophylactic prescription of ACE inhibitors than without treatment in patients suffering from DMD and a preserved left ventricular ejection fraction. In a broader perspective, this is a promising indication for ACE inhibitors in muscular dystrophy. We also found in other studies some effect of early treatment in Becker muscular dystrophy, and this could also be studied in female carriers. Thank you for your attention.
So Leslie, thank you very much for this presentation and for this data that seem to go in the direction of confirming what we already know in the past about the benefits of ACEinhibitors, with probably the addition of the information that very early starting on ACEinhibitors probably gets better results. I guess the age of onset of treatment is very important. And I would like to ask you about the decision of using only ACEinhibitors, not using beta blockers. This is probably because combined, I mean, with ACEinhibitors, which is a common combination of drugs that we use in these patients. Is this because the treatment was started very early, or because you had evidence that the severity or the non-severity of the left ventricular dysfunction at the moment of treatment, at the decision of treatment, was sufficient, I mean, to support immunotherapy with ACEinhibitors? Just ACEinhibitors versus ACEinhibitors plus beta blockers. Did you understand my question?
Yes. I think there are several justifications. It was patients who didn't have any heart disease, so it was a preventive treatment. So I think we choose to apply only one treatment to not accumulate any adverse events if there was any. And the previous studies was shown several effects on perindopril only. So we tried to show the same effects with only ACE inhibitors. But I think there are also other studies on the road for beta blockers. So if there are also concluent like ours, I think it's a good idea to compare one group with ACE only and another group with the combined treatment, of course.
Were these children, Leslie, still walking, or they were already severely compromised?
There was some walking and some lose the deambulation. I can show you. I don't have the screen, but there was 14% who lost the deambulation, the ability to walk.
Okay, and did this condition in some way influence the dosage of the drugs, or was the dosage standard for all patients? Because sometimes they feel very, the dose of ACEinhibitors is very important for their well-being.
Yes. We did also a subgroup analysis that I didn't show to respect the timing, but we also did a subgroup analysis between patients who lost their deambulation at inclusion and the patient who didn't lose it, and there was no significant difference in our results. So.
No, sometimes it's very difficult to decide for us to decide about the dosages of the drugs in the combination in the real life, I mean. And in some cases, we have observed intolerance to beta blockers and also ACEinhibitors. So the alternative drugs that we have, for example, for controlled tachycardia, are ivabradine, or something like that. Did you need to use drugs such as beta blockers or ivabradine to control the frequency, the heart frequency, heart rate of the patients in some cases?
Okay. In the study, there was 17 patients under beta blockers. In the group.
70, okay. The overall, so it means the 70 in 412, right?
Yes.
Do you think that the cause of death sometimes it's difficult for us to dissect respiratory failure and heart failure as a cause of death? I don't know how you do, but sometimes we are not able to say this patient is really failed because of the heart failure or for the combination of the two conditions. Respiratory failure is a very important contribution in the final outcome of these patients. Do you think is something we can do to dissect the two different contributors, or we simply need to consider the sum of these two conditions and, as uneluctable, impossible to distinguish, impossible to separate? I don't know.
So perhaps I can help Leslie with this response because it's not easy. In the study, we adjudicated all events, and when we went through the patient files, it was indeed quite often difficult to differentiate the two types of complications, particularly in patients with really advanced Duchenne muscular dystrophy, because you have the two types of manifestations evolving in parallel. So obviously, this is something difficult. We try to standardize the criteria to define the heart failure using the common parameters, echo, natriuretic peptides. But obviously, sometimes it's difficult, as sometimes patients just have both types of complications at the same moment. Respiratory failure leading to decompensation of the cardiomyopathy. So I completely agree with you, it's not that easy.
There's a question from Perry. He's asking where you are able to stratify the presence or absence or severity of myocardial fibrosis. And on this issue, I would like to add a practical question. It's very difficult for the deformity of the chest sometimes to have a well-done CMR in these patients. How do you manage CMR, and how about the severity of myocardial fibrosis as a contributor of the possible stratification of the risk?
We only use a cardiac ultrasound in this study, not CMR. Because it was a retrospective study, so we didn't have the ability to practice CMR. It was some patients that were following in the year 2000, so it was an early stage for CMR maybe. And we just do some ultrasounds, so we were able to assess the evolution of left ventricular ejection fraction, but that's all for myocardial fibrosis.
Okay.
And just to add a comment regarding Perry's comment, probably treatments who have the potential to delay the development of functional abnormalities when they are initiated early are probably those with the most significant antifibrotic effects. So we expect perhaps more from ACEinhibitors or spironolactone than from beta blockers. And we have those data with ACEinhibitors. They are quite interesting data with eplerenone as well, with the paper in Lancet Neurology a few years ago. And the data obtained with beta blockers have been quite disappointing at the moment. There was a study conducted in the UK which was negative, but there have been difficulties to enroll patients in the trial, and we are currently looking into the data from a randomized trial we have conducted in France. But my first impression is that the study we have conducted with beta blockers has a bit disappointing results. So targeting patients with fibrosis is probably important, particularly when we see patients quite early, because the first referral to the cardiologist is generally around the age of 6 years. 10 years is the age where the incidence of dilated cardiomyopathy increases. And the few subset of patients who have evidence of fibrosis between 6 and 10 years are probably those who are at high risk for developing heart failure when they are teenagers or young adults. So perhaps those patients with fibrosis on MRI, probably those who should be targeted with not only one, but perhaps 2 or 3 treatments.
Karim, sorry, Eloise, I was going to follow that up, and maybe a question for you and Costas as well. So I think one of the dilemmas in all cardiomyopathies, but maybe particularly in this group of diseases, is when do you start the prophylactic therapy? So, you know, you say they're referred for cardiovascular evaluation, maybe on average around 6 years, but is this something that you should start with the diagnosis of the Duchenne? Do you wait until you have cardiac dysfunction? Do you wait until there's some fibrosis? What opinion do you have as to when you should actually start?
Well, I think it's a very important question, a very difficult one. We are not afraid of using ACEinhibitors at the age of 10. We have now data supporting that. An earlier onset of ACEinhibitors in a heart which is still under development has been quite a matter of debate. Some cardiopediatricians mentioned the possibility that starting ACEinhibitors too early could be deleterious. I'm not fully convinced by that. That's the first point. Then we have the question of what strategy would be the most efficient, because we know that 10 years has high impact, but perhaps starting treatments at 6 years could even be more efficient. We have few patients who have been put on ACEinhibitors between 6 and 7 years because there has been a trial assessing the effect on the skeletal muscle function a few years ago. So we have data with patients who have been put on ACEinhibitors quite early, and we will look into that to see if the treatment had a supplemental effect when we were started early. And then very generally in patients with dilated cardiomyopathy or at risk to develop cardiomyopathy due to DMD mutations or other variants, I think this remains really an open question. Probably depends on the natural course of the disease. Is it particularly aggressive? Is it a condition which has the potential to respond to the treatment, such as tendinopathies? So there are many parameters to take into account. And my impression, but it's just an impression, is that we will probably have approaches which may differ from one genetic condition to another. But I would be interested to have your opinion on that as well.
So may I ask you if the functional class, near functional class, is helpful or not? Because in our experience, these patients tend to limit their physical performance. We are never able to understand if they are in class functional 1 or 2. Or do you have any benefit in evaluating the functional class in these patients? Or you know what I mean? They tend to restrict their physical activity. So when we ask about dyspnea, for example, they answer that they don't have dyspnea, which is a common marker of early heart failure. We are not able to take advantage of this information. What is your experience about this?
You mean in patients with muscular dystrophy in general, or in patients with dystrophinopathies?
Also, the deformities of the chest, general deformities, contribute to limit their physical performance. So they tend not to move, to sit at the computer for days, hours, and so on. So when we ask about symptoms, they usually say that they have little symptoms. They don't complain much symptoms in terms of individual perception of.
Yeah, I completely agree with you. I think even in patients with conditions who have an effect only on the cardiac muscle, we are a bit surprised when we do treatment test. Even in HCM, sometimes patients have mild symptoms, and when you just take a look at what effort they are able to provide, you're a bit surprised because some patients just limit their activity. That's the first point. The second point is that patients with neuromuscular diseases, I completely agree with you, since they have skeletal muscle involvement and potentially respiratory involvement, they probably they are even more limited regarding the functional capacity they are able to provide. And so what we generally see, particularly in Duchenne muscular dystrophy, is that we have patients who have a progressive decline in their left ventricular ejection fraction. They have absolutely no symptom, and sometimes you see a patient with 20% of ejection fraction, totally asymptomatic, who is admitted for cardiogenic shock a few weeks later. So symptoms occur really in patients who have almost end-stage heart failure in Duchenne muscular dystrophy. This is what we observe in the majority of cases.
Yeah, I fully agree. Sometimes we have patients with 20% ejection fraction, and no symptoms. They do not even perceive the severity of their cardiac disease. Then there's another question, two questions actually. One is from Alexandros and one is from Teresa. Can you read the question, or should I read it for you? Alexandros,
I can phrase it again. So I was just wondering if we have any evidence of the ACE inhibitors giving any benefit in regards to peripheral muscle function, and whether we understand exactly which mechanisms we expect that are altered by the ACE inhibitors that might lead to benefits in this disease.
Okay. I don't know, Leslie, if you have clues to answer that question. We have some data, but I think we didn't discuss that together. I think there has been a randomized trial conducted a few years ago by neuropediatricians in France with patients aged 6-7 years who have been randomized between ACE inhibitor, perindopril or placebo at that age. And the primary endpoint was skeletal muscle function, the ability to climb stairs, I think the 6-minute walk test. The rationale for conducting this study were data obtained in the MDX mouse model. And in MDX mouse models, it has been shown that you have, even in the skeletal muscle, abnormalities of the angiotensin-renin system, and the muscle strength was improved in this mouse model. But unfortunately, the study was negative and no significant benefit was obtained in patients. So we do not really know if there's absolutely no clinical effect, or if the study was underpowered to really address that question. So perhaps there may be an effect, but probably the effect on the skeletal muscle is not that clinically significant.
Thanks. There's another question from Teresa Castiello from London, which I think is a very, very interesting clinical question. So essentially what Teresa is asking is in which order you're starting your heart failure medication. I mean, obviously, ACE inhibitor is early on, but when you add the other medication, and whether there's any heart failure therapy that is poorly tolerated or not indicated in Duchenne. I think the main question here is when do you start with eplerenone? I think you've said a lot about the beta blocker, but it's when do you go with the second agent, and obviously, to be intriguing, what do you think about Entresto? What do you think about DAPA? Absolutely, yeah, Teresa, got you there.
Well, a lot of things have been done, and there remain a lot of things to do. Have a study with an MRA showing that by the age of 7 years, in children who have evidence of fibrosis on MRI, when you start eplerenone, then you have a lower proportion of patients who you have an improved myocardial strain, circumferential strain on MRI, and probably a slower decline in the ejection fraction. So we have this single study, and we have also preclinical study showing the same effect. So the global trend is to use MRAs in children who have, or in adults who have normal ejection fraction and evidence of fibrosis on MRI. So this is based on the result of one study. For beta blockers, we have a study conducted in the UK that was negative. So the indication for beta blockers remain quite unclear. What I do, but it's completely empirical, is that you have almost all patients who have sinus tachycardia. When patients complain of their heart beating fast, they have palpitations, then I tend to put them on beta blockers, but there's no proof. And for other treatments, I think this is we have absolutely no clinical data for other heart failure treatments, particularly SGLT2 inhibitors. So, but what I do is that I put patients on those treatments when they have really significant LV dysfunction. We just discussed that patients generally do not complain of any symptoms, and when they have a significantly reduced ejection fraction. Regarding the extremely severe course of the disease, I tend now to use this treatment as well, but it remains completely empirical as well.
What's your view on steroids for heart failure? I know mostly we don't really, the cardiologists do not really control the indications for steroids because generally they will be prescribed by the neurologist for prevention of to reduce the decline of the muscular function. But we do have some evidence that steroids may be actually quite helpful in cardiomyopathy. And I mean, my question is obviously whether we can do, or whether it's possible to do a similar, statistical analysis or process, in the way that you've used for the ACE inhibitors with steroids. But
well, all the studies which have been published to date with steroids were based on the analysis of observational data, have quite robust studies regarding the methodology which has been used, and all studies showed probable benefit on the myocardial function and even on long-term outcomes in patients with Duchennemuscular dystrophy. So perhaps this treatment is beneficial when it's initiated early. Sometimes you have a discussion on whether you should continue corticoids when patients have lost ambulation, they are older, they have side effects with the treatment, osteoporosis, and so on. And some practitioners tend to continue the treatment to protect the cardiac function. I'm not totally convinced that the benefit-risk ratio is favorable in older patients, particularly in adults. And to answer your question on doing the same study with steroids, we are looking into our data, and this is one thing we try to we want to do. And our first impression is that the treatment is beneficial, even when you analyze large set of data with many patients, long-term follow-up. My impression, it's preliminary, but it's probably that that's obviously a beneficial effect on the progression of heart failure and long-term prognosis as well.
Thanks. To stay on the topic, Perry is asking in relation to that, what we think the mechanism of heart failure is. I think that's a bit of a provocative question, Perry. But I think this is what's the mechanism of heart failure in Duchenne, whether it's purely atrophy or dystrophy, and obviously genetic, or there's an inflammatory component. What's your view on that?
I don't know. I was hoping Eloisa would answer that question.
Oh yeah, or
Perry, let me tell you that in all of you, we search inflammation in the hearts of these patients. Obviously, they are not Duchenne. Duchenne patients do not usually reach transplantation, but Becker muscle dystrophy patients, we could never identify cases with a consistent inflammation, chronic inflammation, whatever. And I tell you more, also the fibrosis was far less extensive than what we had suspected before. And again, many of our patients who underwent transplantation, 15–20% ejection fraction, had an ICD in primary prevention since many years. And we did not record appropriate ICD interventions. Rather, we had some infectious complications, a number of secondary complications, but very, very rare ventricular arrhythmias in this patient. So I guess we should be careful in considering inflammation as a mechanism. In terms of cellular inflammation, of course, then if we can eventually consider a systemic cytokine-mediated inflammatory state, that it's another story, but not inflammatory cellular inflammation. I totally not, I haven't seen it. So. I don't know, in France, did you have some experience with the pathology of these hearts? Leslie?
We have few patients who had LVADs, and in the myocardial samples, we had lymphocytes, not so much necrosis, but a bit of necrosis. But I don't know if that was really specific or if there was just something happening in the setting of terminal heart failure. And in Duchenne muscular dystrophy, my impression is we have probably the two types of mechanisms, a very progressive development of fibrosis, atrophy, dystrophy, a kind of dystrophic process, which probably responds to treatments such as ACEinhibitors. And sometimes patients can have kind of hot faces, like we can see in other genetic cardiomyopathies. For example, it's not the case for all patients, but it's not exceptional that patients with Duchenne muscular dystrophy, children, teenagers, sometimes adults, are admitted for kind of myocarditis with chest pain, elevation of troponin I, and sometimes an inflammatory pattern on MRI. It has been published by colleagues in the US. We have seen that in quite a few patients, but not all patients. So I think there may be the combination of the two processes, and but this is something that remains quite obscure. And I think, I don't know if that could be an explanation for the beneficial effect of corticoids started early. Because we know that in the skeletal muscle, there's inflammation. Has been shown on biopsy, and when you take a look at the protein or RNA expression patterns, you have an overexpression of inflammation, and particularly when the disease progresses fast. So is there the same process at the myocardial level, but perhaps that could be an explanation for the protective effects of glucocorticoids, but I don't know.
Thanks. Sorry, I think very important point that Eloisa brought up as well about the mode of death,
Yeah.
and cardiac death, and I think we're coming back to that, quite often. Karima, from your data, and from our experience, it doesn't seem that the arrhythmic death is really the main thing. Is really heart failure death, isn't it?
So, but they usually implant an ICD irrespective of any stratification of the risk, but simply because the ejection fraction is very low. This patient can stay 10 years, 15 years with the ICD implanted without any intervention. So the question is, what are we doing? Do we have any tool for making a reconsideration in primary prevention in these patients? Because we have possible complications. What is your opinion? I don't know. Myself, when it's possible, I try to prevent ICD implantation, even in the presence of low ejection fraction.
This has been our practice as well in London, to be quite restrictive, and I think this is the general feeling, and I think this is also where the guidelines are going to be moving quite soon.
Yeah, I completely agree with you, 100% agree with you, but some colleagues in the US are pushing to put ICDs. You have a couple of patients who die suddenly, and then you just doesn't really make sense. My impression is that you have arrhythmogenic cardiomyopathies, and you are cardiomyopathies who are strikingly associated with the low risk of events, even when there's a huge fibrosis burden. And this is the case of dystrophinopathies. It's the first thing. And there are very few arrhythmic events in the atria as well. It's not only the ventricles, it's globally not that arrhythmogenic. That's the first point. The second point is that you have chest deformations, you have many things that increase the morbidity associated with the placement of the devices. So I think you can put an ICD, but the risk of complications is probably higher than in other patients. And the third reason, in my opinion, for not implanting systematically an ICD is that the discussions we have, particularly with the Danish study and the competitive risk of death due to heart failure. In Duchenne, you have a competitive risk of death due to heart failure, due to respiratory failure, and potentially due to other causes. So the global benefit in terms of sudden death prevention, in my opinion, is very low. So we really tend to implant patients who have a quite good quality of life, have respiratory failure, but not that severe, and you have overt ventricular arrhythmias. That's the only indication we have in Paris for implanting patients.
There are a couple of questions from the audience. One is about the class effect of ACE inhibitors. Do you think it's a class effect? We can use any ACE inhibitor, or is it perindopril the only one that is taking the role here?
Most of the studies which have been conducted included patients with perindopril. That's the reason why we still continue using perindopril. My opinion is that it's just a class effect, but we do not have any data supporting that. But I think it seems reasonable to think that, and I think it's not a problem to use another ACE inhibitors, in my opinion.
And Teresa is asking about the epicardial fibrosis in the CMR and what your best guess would be that this represents. Inflammation, fibrosis, no specific change. And I think we know we probably have quite a lot of anatomical, pathological data as well on that, and maybe Eloisa can jump in.
Well, for my side, I would see with my eyes this epicardial fibrosis. I'm not fully convinced. It's becoming a long story now. The Q-wave on electrocardiogram as a marker, the fibrosis in the inferior wall. I'm not sure that we have seen all these evidences in order to make assumption or conclusion. Fibrosis is quite variable in this heart. Sometimes it's in the septum, sometimes it's in the apex, sometimes in the wall. So I'm not sure. And the epicardial wall, the left ventricular walls of these patients are very thin. I'm not sure that I would make consideration if I'm not able to have a baseline information and to have parallel and serial comparison of the evolution of the structural, fibrosis. I don't know what my colleagues in France think about, but I would be very cautious because in the past we have concluded a little too much with respect to what we have observed in vivo.
Yeah, I agree with you. Leslie just went through data we have collected in patients with Becker muscular dystrophy. Can you please let us know what we found in patients with Becker regarding the localization of late gadolinium enhancement? Do you have the numbers in mind?
I may not recall the proportion, but the main distribution was epicardial and medioparietal, mostly in the lateral wall for Becker.
Yeah.
But may I ask you if you ever observed diastolic dysfunction in these patients?
It's going to be there, Eloisa. I mean, but it's, I mean, if the cardiomyocytes are not working, they don't work in diastole, just in the same way as they don't work in systole. But it's, but do we see restrictive cardiomyopathy? No, Costas? No, we don't see restrictive.
I don't think we've seen restrictive,
No.
even the very, progressive DCMs.
Can I come back to this issue of why don't they die suddenly?
They don't die suddenly.
I know, but why? So, it's completely contrary to the modern paradigm, isn't it? Of, as you said, low ejection fraction, but also extensive fibrosis. So if we want to roll out patients to counter the argument that all fibrosis means sudden cardiac death, dystrophin is a great example to do that. But it must have some, it's got to have, it's more about the muscle around the scar, isn't it? It's about the cardiomyocytes around the scar and what their ability, their propensity is to support a ventricular arrhythmia. And in this disease, it just doesn't seem to happen.
Yeah, I think we always have discussions on the substrate of ventricular arrhythmias, and you have re-entries, fibrosis. I think it's perhaps more complicated than that. Probably things happening at the tisular, cellular level with the electrophysiology is probably far more complex than that, and the correlation between fibrosis burden and arrhythmic events is not that good when you compare one disease to. So I think we have perhaps a simplistic way to explain arrhythmic events. At some point, I had the impression that they didn't have arrhythmic events, patients with Duchennemuscular dystrophy, perhaps also because they are non-ambulant. Some events are triggered by exercise or following exercise, but it's pretty much the same in patients with Becker muscular dystrophy. Sometimes you have patients who have a kind of X-linked GCM. They have a huge fibrosis burden. Have so much fibrosis, sometimes you need to take a look at the MRI, you think that patients had myocardial infarction. And in the end, even those patients, sometimes who do sports, they have very few events in the ventricle and in the atria. So yeah, I completely agree with you. There's something perhaps more complicated than just fibrosis.
Yeah. I mean, Alex is asking on this point whether it's all fibrosis or is it fibrofat infiltration. I think there is quite good amount of data as well that there is fibrofatty changes that we've seen, and I think this is what we're seeing in the peripheral musculature as well, quite often. And Max is asking about the acute myocarditis. I think we've you've mentioned before this quite. I mean, we've had quite a few episodes as well of acute myocarditis, but I think these are well described in the literature as well. No, I mean back to the mode of death. I suspect, as you suspected, that potentially the activity is a significant trigger, and also we never see NT-proBNP high, apart from people that are quite progressive in their heart failure. So probably will have some effect to do with stretching of the heart and stressing and potentially activity. But as you said, this is not what we see exactly in the Becker, especially with some that are particularly active. Although maybe the numbers are maybe too small and they're quite biased. Yeah, so Perry, you're asking about the X-linked dilated cardiomyopathy, and that was one of my questions actually on my to-do list, to ask before, and whether, I guess, what X-linked dilated cardiomyopathy caused by dystrophin mutations, whether you think we should be having the same pattern, the same management in those patients as well.
Yeah, but where are they all? Eloisa, you do you still see this?
Many of our transplanted patients are patients who present X-linked dilated cardiomyopathy with mild muscle involvement. So consider a spectrum in Becker. On one side, the Becker that is most similar to Duchenne. On the other side, the Becker who has very limited muscle involvement. Then probably patients who first come to our attention as a cardiologist are exactly those with very mild muscle involvement. And so I think it does exist that these patients after transplantation behave as other patients. Eventually, I'm considering the benefit of steroid treatment after transplantation due to immunosuppression, which is not obviously planned for treating the muscle, but probably the steroids, are contributors to in maintaining the skeletal muscle in a stable condition. We have patients who underwent transplantation more than 20 years ago. Usually mutation in the mid-rod domain, the same data that Leslie showed before in the list of mutations of defects, I guess. Leslie, you had more mid-rod domain mutated patients, I guess, right? Or this was in the paper, I don't remember. Deletion of exon 45, 55, something like that. This is very, very common. Do you have this evidence?
Yeah, I think Kostas, tell me, we've looked for it. We just we're not recognizing it very often. And certainly on genetic testing in DCM, we're not finding very many of these cases.
No. We've got a couple of families, and I think, I would, genetically speaking, from the type of mutations that we see, I think there's, these X-linked, these DCMs, Duchenne DCMs, there are something quite specific, because, they will have also, quite deletions and large deletions in the dystrophin. Whereas Becker's, they're going to be almost all of them. They're going to be in frame deletion, and they will have some disruption. And then the Duchenne, they will have, again, very radical mutations as well. And I just don't quite get, how you get this differentiation between the Duchennes and the
Beckers
and the X-linked DCMs. Yeah. But yeah, we don't see as many as we saw before.
Yeah.
But there are out there.
Yeah. And what about female patients? What do we think we see in older women, Duchenne carriers?
Well, I think there are a nice study has been published I don't remember exactly when, in JAMA, showing that the whole prevalence of DCM with the old DCM criteria was between 5 and 10%. So when you compare the prevalence of dilated cardiomyopathy in Duchenne before the area of prophylactic treatment, In adults, it was 70, 75. In Becker, you have perhaps 35, 45%, and in female carriers, it's even lower. And the main difficulty in female carriers is to arrange their follow-up, because when you have very low level of risk, it doesn't make sense to see patients on a yearly basis. And on the other hand, if you just say patients will make an appointment in 5 years, you never see patients again. So it's quite difficult. What we try to do is to investigate them very carefully at diagnosis. We do an MRI, we check the CKs, and we see if there's any phenotypic manifestation of the skeletal and cardiac muscle. If everything is normal, we just say them, well, do an echo in 5 years and see what happened. And if we find even subtle abnormalities, we try to arrange a follow-up without worrying too much patients. But it's not easy.
Perry, may I make a point on genetic diagnosis? Unless we perform systematic screening for copy number variation, we miss this diagnosis. Or alternatively, if we use a multi-gene panel, we need a special pipelines for recognizing copy number variation. So, I mean, it's 20 years that I have same prevalence in consecutive males. From 5 to 6.5 to 7%, it supposed also to maintain the percentage of 5% in consecutive males, but you should search for. You know, point mutations, stop, small incel, whatever, are very rare. 80% of these patients have a copy number variation. So I think we should systematically use the right tools to get to this diagnosis, which is very important that is shared by different groups, because otherwise each of us comes out with different values in prevalence. I think it's very simple. Copy number variation, it's easy to be tested, but it should be done systematically in consecutive series. Not with increased serum decay, you know.
Okay. So Karim, what's the take-home message?
The take-home message for patients with muscular dystrophy is that you must have a systematic prophylactic approach based on ACEinhibitors as the first-line treatment. Be initiated the latest at the age of 10 years, because the potential to...
What a tragedy. We get to the final message and the, and the link goes down to Paris.
So perhaps I should leave Leslie.
Okay, we're coming to the end now. So Karim, Leslie, thank you. I mean, really great data. Congratulations on getting the paper published. Eloisa Costas, thank you for sharing so well, and thank you everybody for attending. I think another great meeting. And so we look forward to seeing you again next month for the next edition of Heart Muscle Talk. Thank you very much indeed.
Thank you very much.
Thank you.